Good morning.
Good morning. How are you?
Great. So we had some great episodes today. The first one being Peter Burks.
Yeah, it was really, really good.
Yeah, we know him from The Office, and he is very connected with the BoneScore procedure.
Yes, this is a new way of testing bone strength and hopefully being able to predict or prevent, more importantly, bone fractures that are a big problem for postmenopausal women particularly, or actually any really aging person. And this is just, I think, setting the industry on its head. It's really exciting, and I think you'll really enjoy hearing about the technology and how it came to be.
Yeah, and he also kind of clarifies the difference. The question we get asked a lot is, what's the difference between BoneScore and bone density? So anyway, it's a great episode. Enjoy.
But what do I know? I'm just a vagina doctor. Peter Burks, welcome to the Vagina Doctor podcast. How are you?
I'm doing excellent. Excited to be here.
Great. It's great to have you. So for accuracy, I'd like to read the bio that our guests give to us, because I want it to be right. I think it's important. So according to your bio, your professional curiosity lies at the intersection of entrepreneurship and scientific discovery. Currently, you serve as the CEO of Active Life Scientific Incorporated, a medical device company that is transforming the measurement and monitoring of bone health. The company has introduced a groundbreaking method for assessing the strength of bone tissue known as the BoneScore. The medical device is approved for use in both the United States and Europe and is utilized by physicians at prestigious medical institutions on multiple continents. Before venturing into the business world, you were a published scientist in the fields of nanomaterial synthesis and photochemical drug delivery. You have a PhD in chemistry from UCSB, along with a certificate in technology entrepreneurship from the UCSB Technology Management Program. Accurate?
I think so.
Okay, good. So this is the Vagina Doctor podcast. So what are we doing talking about bones? Okay. For our listeners, you're in the right place. We are the Vagina Doctor podcast, and we are talking about bones. The reason for that is the North American Menopause Society has recently become much more interested in bone health because of women living longer, being more active, and the statistics of 50% of women in menopause having a bone fracture due to osteoporosis at some time. So thanks for giving us another tool. How did we get here? What happened? Tell us the story.
It's a fascinating story, and it really begins with the inability to predict a patient's bone strength. And it manifests with physicians. So many times physicians will see a patient, and that patient will have what's called a low energy fracture. So physicians will call it an osteoporotic fracture, but what it means is that you fell during an activity that your body should be able to withstand, but your bones were unable to do so. So this could be standing, they call it a fall from standing height.
Yeah.
It could be picking up a grocery bag. It could be picking up a grandkid. And all of a sudden you have a fracture in the spine, or even worse, a fracture in the hip. Oftentimes the first fracture you see is in the wrist because someone tries to brace themselves as they fall. And so what physicians found is that the vast majority of patients that had these fractures didn't have osteoporotic bone density. And so the question became, what exactly was causing these fractures? If their bone density was normal or slightly low, which they call osteopenic, that doesn't necessarily mean the physician says you have bone disease. It's not until your bone density goes all the way down to osteoporosis where they say you have bone disease.
Yeah.
So the question became, bone density is giving us part of the picture. How do we get the rest of the picture?
Let's talk about, explain bone density, because even women, my friends, when I say DEXA, they don't even know what I'm talking about. Okay, so let's just talk about that for a second.
Absolutely. I think the easiest way to think of bone density is like casting a flashlight with a shadow. So in order to understand how much mineral is in your bones. So these are the calcium phosphate atoms, like how much mineral is in your bone. They shoot an X-ray through your bone, and wherever there is mineral, the X-ray moves away and you get a shadow. And how dark that shadow is tells you how dense the material is. And this is how we do bone density scanning. So you get scanned with X-rays, and the doctor is getting a numerical assessment of how dark the shadow was on the other side. And the basic idea is that the more dense your bone, the stronger your bone. The less dense your bone, the weaker your bone. And
what age should women be starting that bone density test?
so it's a fascinating part of this is that our view as a company is we would like people to start thinking about bone health at a much earlier age.
Yeah.
Typically when we talk to patients, most female patients will say, the first time I was exposed to this was with my OB. And they had said, you're walking into menopause and this is a part of life and we should start taking a look. Between 55 and 65 is where you'll hear most of the conversation happening. And then after 65, it becomes a regular part of the conversation for women. Oftentimes they punt that out for men out to 70 years old. Because on average, women are going to experience more bone fragility than men. However, what people don't pay attention to is that when you look at the statistics about the poor and negative outcomes that happen after a fall or after a fracture, men actually do much worse than women. So even though they don't fracture as often, their outcomes are much worse.
Right.
So it's something men have to think about too.
Yeah, I've noticed that too with men. It can be the beginning of the end when they fall.
Yeah, it's scary when you see the statistics after a hip fracture. Following 1 year, the rate of death is very high. And it's typically death due to something else because the patient becomes bedridden, they get an infection, something else comes on. But when you fracture a hip, your mobility is dramatically impacted, often permanently.
Yeah.
And for both my grandparents, they were part of the statistic, which is within a year of a hip fracture, they had passed. And so it's a real statistic, but they didn't pass because of the hip fracture. It was just the lack of mobility. Your body needs to move. One of the things, not to distract us too much, but one of the things that really gets us excited about bone is that people don't think about the fact that the scaffolding of motion is your bones.
Yeah.
Right?
Yeah.
Without bones, we're little puddles with all these cells.
Right.
Going on,
It's like the tires on a car. Your car is only as good as the tires. So we are only as good as our bones, right?
And spinning back to the question you asked, that's where we were motivated to do something different. We wanted to try and understand how good is the bone, not how dense or how much bone do you have. Our motivation was, could we figure out how good the bone is? Because we think that's a better indicator of whether you have healthy, strong bone. And our view, our like grander vision is to provide this metric of bone health that you start thinking about bone health at a much younger age.
Like how old?
I would love people to have it as part of their annual physical in their 20s and 30s, because why wouldn't we track our overall bone health? Like, why wouldn't we sit back and say, how should I be exercising? How should I be eating? What is perhaps disease? How are these things impacting my bones? You start getting blood panels in your annual physicals at, I don't know, I think my first one started at age 30 or something like that. But I think that bone health should be something that isn't a part of late stage life, but a part of our lives that we can think about earlier and ideally with better understanding at an early phase, then perhaps we can take actions that push away the deterioration of bone health as we age.
The other factor in this is women generally are more susceptible, but it starts way before menopause for some of them, and it starts with pregnancy and postpartum time. And I've seen patients with osteoporosis, and not necessarily with fractures, but just that diagnosis has been made at some time in 20s and 30s. And if they're not aware of it, it does, for those of us that do have weaker bones, we can moderate our activity too. So we're not taking undue risks. We're not riding horses or racing bikes, motorbikes.
Yeah, when do you, Duncan, suggest that your patients start looking at bone health?
really just my demographic is the right one, and it's just from basically menopause on. So I don't normally do that unless there's some other reason to look.
There's areas of bone health that you don't always think about, and I can speak to them from research that we are currently performing and have performed. And I can also look at it from the patient input. So we get physicians calling us that have issues with young collegiate female athletes that will start having bone issues. They call it the female athletic triad.
Right.
And, that's an area where, again, in the peak of life, you would think we don't have to worry about bone at all. But there's a case that this happens. And then the other area where it's happening at
is that a hereditary component there? Or is that from too much physical activity, or what is that?
All of the above.
Generally speaking, it's all of the above.
Okay.
And it's the impact on the female's body by hormonal changes, weight changes, and how all that works together. The other space where it's been actually a big issue that is trying to be resolved is the military. So as more and more female recruits have worked their way into the military, there is higher stress fracture rates. And so the military is trying to figure out, how do we identify patients that are going to have these issues during basic training? Because if their bone deteriorates during basic training, it can be a big healthcare cost for the military, trying to keep those patients rehabilitated or get them rehabilitated. So bone health is not just an old person issue.
Right.
And if I could share a message that gets people's attention, is that you should be thinking about bone health earlier. And the question should be, what can we do and how can we improve it? And, right now there's only, really one main stage metric out there. And that one main stage metric on average says that you don't need to worry about bone until you get old. And that's why we said we need to bring in a totally new dimension to look at bone health, to try and provide a metric that can give people a vantage point into their bone health throughout their continuum of living.
And this was developed at UCSB.
That's correct. And this is credit to Dr. Paul Hansma. He was a physicist at UC Santa Barbara. And then he worked with my business partner and company founder, Alex Proctor. And essentially what they did to think through it would be that for years, what people thought essentially the way they wanted to try and understand how strong your bone is they said, if we can just take a higher resolution picture of your bone, then we can ultimately solve this problem. And so lots of money went into making an X-ray better, making a bone density scan better. And what it did is it made that equipment bigger and more expensive and ultimately not as effective as they had hoped. So the kind of genius that Paul Hansma and Alex thought of is they said, orthopedic surgeons have been touching bone in the middle of a procedure for decades. My father's an orthopedic surgeon. They go in, they push on the bone with something sterile, and they go, ooh, this is not very good bone. Or they go, ooh, this is really good bone. And that assessment has just never been available. And so we said, what if we could package that touch into an assessment that can be quantitative, that can be minimally invasive, and something that's easy enough that it can be performed by a nurse during a routine office visit. And that's ultimately, over a decade of research, what we ended up bringing to the market.
And that's when our conversation began. It was before COVID. It was pending FDA approval of the test. And I don't know how I heard about it, but somehow you and I were in touch. And I was really excited by this. I thought it was just a really great step forward if it came to pass. And then, of course, everything went into hibernation for a couple of years. And but you showed up again, and with now FDA approval and everything ready to get going. And so we started doing it in my practice. And it's been exactly what you say. It's minimally invasive. It can be done by an RN or a physician. And it's essentially painless. It's, in fact, personally, it was completely painless. I didn't feel anything but some pressure. And it's reproducible and it's accurate and it's sensitive. So great stuff.
Yeah, I think I'm at this point the most tested human on the planet, and I've not had pain, and I've obviously had it performed on me by folks who are training or new facilities and things like that for years. My view is that you can, like, the key point is that bone density is giving you one vantage point. Mm-hmm. What we're doing is not bone density; it's something different. And I would describe that as the motivation for bone density is trying to figure out how much bone do you have, how dense are your bones. And our motivation for creating this was to try to figure out how good is your bone tissue. And that's why our test uses touch. And really the only way to get that information, people say, can we get this from not, having a touch-based test? And it's like, no, because the only information or the only people who had access to this information was orthopedic surgeons before this.
And open surgery.
Correct.
So should I describe a little bit of the procedure?
Sure.
For patients? Patients come in sometimes just for this. They call us because they know we do it. We take a history and generally are aware of what medications patients are taking, but there's no obvious contraindication to this. If somebody's on a blood thinner, we may tell them they may bruise a little more, or they might bruise because usually there is no bruising. We just use an antiseptic solution on the shin bone, best put for the layperson. And then we put a local anesthetic in the skin. And then we use a probe which comes into contact with the bone through the skin and delivers a calculated impression on the bone, measuring the response of the bone. The test itself takes about 15 seconds. The procedure takes about 15 minutes, just with the preparation and talking and consents and so on. And we immediately take that instrumentation and compare it with a reference block of material that is a consistent hardness. And that qualifies the test that we've done, and it gives us a number right there and then. It's reproducible, meaning we'll get the same result the next time. The patient then just has a Band-Aid over the skin. It's like just having a COVID shot or a flu shot or a little local anesthetic in the skin. For me, as I say, it was completely painless, even done by one of my staff to me. So they did really well. So, it's phenomenal. It's,
and then what do you do with that information?
Good point. Thank you. Yeah. Thanks for the question.
Yeah.
It's yours.
Yeah. What do we do with this information? Then what?
I'll walk through what the experience is. So upon the completion of a test, you get a score. Mm-hmm. And the part that people have to think about is no one had measured what we've measured before. In fact, our clearance with the FDA is a de novo clearance, which is a specific type of clearance that's hard to get, that is essentially for something that is a completely novel device that's never existed before, but is considered very low risk, very safe. So we got our de novo clearance, and we had to communicate to FDA, well, what does this mean? So we were Fahrenheit before temperature existed, right? So we created the scale. And the scale is known in the published literature as the Bone Material Strength Index. So this is what people publish. Ultimately, we condense that down to the BoneScore. Humans show up between about 40 and 100. And what we found in the published data is that healthy females are centered around a 79. Healthy males are centered around an 85. And so when you get the score, first it's, okay, what is my score? Let's pick a number. I got measured a couple days ago. I scored a 79. So what does that mean for Peter? I'm not a physician, so I can't give a diagnosis on it. But in short, I look at it, and typically the physicians will look at it and say, okay, well, healthy males around 85. The population is typically from 85 to about, 78, 77. So I'm, within what we would expect for an average male. But if my score is low, for example, if I had scored a 60, then we would say, okay, the bone did not respond very well to this test. So the physician says, all right, well, let's take a look at other types of factors. So it could be what's underlying conditions, disease, what's going on with their bone density. I mean, standard of care is still bone density, so they'll be looking at that. And then trying to piece together what the picture looks like. So for example, when we've heard things, and I think some of them come from you, but there's been patients where they got a bone score, turned out low. They weren't even thinking about bone health. They talked to the physician. Physician said, why don't you go get this and that? All the tests came back, and turns out that their bone's not in a great place. Their bone density was low. They needed something. And then oftentimes there's patients that are in the opposite boat. Their bone density is low, and they're looking to the doctor to say, is there another way that we can look at my bone to try and get a better understanding of what's going on? And then a good portion of the patients who contact us typically show up in that middle area in bone density. So again, you either have healthy normal, you have osteoporotic, or you're in this sort of middle space called osteopenia. And that's a big motivation for the patients that reach out to us, is they're looking for doctors that they can do additional assessments, because they go, do I stop skiing? Do I stop doing the things I love? Like, do I have a problem? Do I not? And getting the more data you have as a physician to make an assessment. What people don't realize is that ultimately physicians are making an assessment in that case. There are no perfect answers, right? And
is osteopenia like a pre-osteoporosis?
That's how it's viewed. Yeah, okay. It means that your bone density is starting to deviate or decrease from that of a healthy 30-year-old. So the references are essentially back to a healthy 30-year-old.
So if it's a female, I know we look at hormone replacement therapy and we look at supplements, diet and exercise.
What do you do next, right?
Right. What do you do next?
Yeah. So we have studies that have shown that certain drugs on the market can improve your bone score very quickly. And there are kind of two classes of drugs that are out there. There's one that is widely used that's classified as a bisphosphonate. That one is sort of your most common approach to get ahead of osteoporosis. There's a lot of discussion about whether that's a good idea or not. And then there's some drugs that have come in.
Why?
It becomes an issue that you get different sides debating. But in short, some people say maybe we shouldn't be providing bisphosphonates at an early age, and then the patient just stays on that treatment forever, because there have been cases, this is a low probability, but there have been cases where patients get what are called atypical fractures, where their bone breaks in a way that is weird. And what there's concern is that if you're on bisphosphonates for too long, that they can cause brittleness in your bone that leads to these fractures. And they caught a lot of press. Again, it's a low probability, but they caught a lot of press, and patients are aware and they don't want to be on that drug.
Right, they don't. Yeah, I hear that.
And I understand that. And honestly, we've seen that patients that have been on it for a long time in studies, that can impact their bone score. And so the next question is, there's other drugs that can be performed that can increase your bone score quickly that are anabolic drugs. But I think where a lot of people, at least when I talk about bone health with folks, where they're really interested is, what can I be doing in my lifestyle to make things better? And we know that impact exercise can improve it. There's been a published study on that.
So go into that. Impact exercise, obviously there's the obvious things, but go into that for, what does that look like?
I would love in a short period of time to be able to come back and show exactly what I desire to see there. But in short, what it means is some of the classical words that are thrown around for bone health, which is weightlifting, it's impact like jumping, running, things that challenges your skeleton. What we don't know, because we're still new kids on the block in bone, is I can't tell you which one's best, which one works for you, how can BoneScore give you a better game plan. But that's our aspirations for it, is to provide a metric that can help physicians and patients see how what they're doing on a lifestyle basis is potentially changing what's going on in their bones. Because for the most part, they're invisible to us, right? We don't think about it. But in terms of what they should be doing, I mean, it's pretty well established that weight-bearing exercise is very important.
Right.
And
that lean muscle mass and being consistent with it.
yeah, it's tough because there's so many different styles of exercise. Certain folks have things they really like and things
Like
that don't.
yoga. Like yoga wouldn't be helpful for bone.
We don't know, you know. We don't know. We haven't had a chance to get in there and see the impact of yoga because one of the things that I think has been shown is that when the muscle is getting tense around the bone, that's part of the process as well. So it's not just slamming into things, but it's the muscles really almost like a boa constrictor grabbing around the bone. And so different types of exercise could stimulate that and potentially make your bones better and better. And we hope that with, you know, time, we'll be able to give people insights into that based on what we're doing.
And what about diet? Sorry. Go on.
So today, in terms of us, diet is something that we've not had a chance to explore. Okay. I think that could be something that really opens the doors. We are very eager to learn more in that space. But for now, I would have to fall back on the typical things that are said about improving your vitamin D, your calcium, and so forth. But the truth is, we don't know. Yeah. And it's not just us. It's medical
Nobody
as a whole.
knows.
Nobody
Right.
knows. And I think there's probably a lot more potential there than we're giving a shot to. Because we haven't been able to measure anything.
Now, there are other things that have been used in the past to try to evaluate bone strength, like ultrasound and spectrometry. Do you have a comment about any of those technologies?
Again, the more data out there are viewed, the better. But oftentimes, so ultrasound was ultimately trying to get a better way to measure bone density. And what we would argue is that bone density as a premise of bone strength, we would challenge that premise. Okay. Our view is that is not the pinnacle of completely understanding the strength of a patient's bone. And so ultrasound was a mechanism that could be cheaper or widely accessible in rural areas, lower cost, to essentially try and estimate the density of the bone. And in the medical community, it's something that's still used, often used around the world in areas where it's harder to get access to a bone density scanner or a DEXA machine. But when you talk to the medical community or you look at trials going through FDA and things like that, the belief is that the gold standard is a full-on DEXA machine, which is the size of this table here.
Yeah. Let's just say you get a patient coming through and they're their osteopenia on the DEXA, and then they get their BoneScore and it's low. And then we say, all right, let's look at all these, let's look at the supplements and let's look at your diet and let's look at your exercise. And they make little changes there and commit to a plan to see if they can do better with their score. When do they come back and test again? How long does it take?
So one of the things that's held up people paying close attention to bone health has been that on average, you don't measure somebody with a bone density machine, a DEXA, frequently. It's typically something that's recommended at once every 2 years or once every 5 years.
I do it every year.
And so folks who start to really worry about their bone health will get them more frequently.
Yeah.
And they accept, getting exposed to radiation and doing that process. The thing that we try to do is by providing a new metric, we tried to say, well, can we get an idea of things that are changing faster? Because your bone density on average doesn't change very fast. For a lot of patients, they'll come, or I should say for a lot of physicians, they'll come and say, well, if I see no change in bone density, even when I'm treating a patient, I consider that a victory because the bone density just doesn't change much. And what we know is that from published studies, the BoneScore can change, and it can change rapidly. So there's been published changes in as short as 3 months. There's been changes actually in as short as 7 weeks. So the question becomes for that patient, when would a doctor want to take a look again?
Yeah.
Ultimately, our view is that if the physician feels that things could have changed in a shorter period of time, patients would be thrilled oftentimes to have some information within the first 6 months.
I think so too.
If not sooner, but ultimately the physician makes that choice. But I think what patients are looking to do is get some indicator, like, is what I'm doing having an impact? What is something changing? They don't even need to know if everything's perfect. They're just curious. Because it's a high risk game. When you have those osteoporotic fractures, it truly is life changing, and it's hard on patients. It's hard on families.
Yeah, it is. It is in the patient's control, though, right? If we give them this information and say, "This is what we recommend you doing," that's in the patient's control to do it.
Yeah, it is. Well, this brings up the other subject, which is the cost. And at this point, insurance companies have not, to my knowledge, been covering the expense of this. So there's no contraindication to repeating a test because there's no complication that we've come across as caused by the test. So there's no risk in that way. So it really comes down to the how soon you can look at something and appreciate a change. And as you said, it's been 7 weeks and one occasion. So 3 months to 6 months is not unreasonable to repeat the test. If somebody's made a huge change to their activity and their diet and their supplements, that's very reasonable. There are 3 providers in Santa Barbara that are doing this test. Is that correct?
Yes, correct.
Where else?
So
I mean, in the state, the country,
yeah,
the world.
So it's going to be changing. It's going to be growing quickly. Without getting into the specifics, you can get this test in Nevada. There's a site in Reno that is doing it. We're going to be spreading into Los Angeles soon. There will be a couple of sites in Los Angeles that will be able to do the test. And then we're going to be spreading to a facility in Florida. And then hopefully, fingers crossed, a couple of major brand name medical institutions will be implementing the test in the early part of next year. And these are the type of medical institutions that people know,
That's great.
widely. And so what we're trying to do is get the tool in the hands of the most innovative physicians, people willing to think outside of the box, because we know that cash pay is part of it, right? And so the physicians have to be comfortable with that. But once they are, they're asking us for the test, and patients are asking for the test. In fact, we even had an anecdotal story the other day where at one of the major medical institutions, a patient had asked the physician, "Hey, can I get this test?" And they'd actually brought in published literature, scientific studies from our device to say, "Hey, are you guys offering this?" And so we know that there is a strong motivation on the patient side, but getting into those facilities and getting into more practices is something that we're excited to grow.
Do you think patients are just doing their own research and finding BoneScore and then being intrigued and then asking their provider? Is that the journey?
I think it is.
Yeah.
Obviously, to reach the masses, you go beyond the patients that are willing to go the extra mile, right? It's only a small portion of the patients that are willing to go the extra mile. But because this problem is so big in the United States, even that small portion of patients willing to go the extra mile is hundreds of thousands of folks, right? And so there's a demand nationwide for getting more metrics about your overall skeletal health to be able to get a more customized picture of what's going on for you, and what your risks are as you age.
Right.
There was an association with some scientists in the Netherlands. Can I say that properly? Netherlands. Correct that for me, please. What was that?
So we began in Europe, and one of the first few physicians that saw what we were doing and was compelled to join the effort, there was a physician in Barcelona named Dr. Adolfo Diaz Perez, who played a vital role, very forward-thinking, osteoporosis-minded physician. And then through him as a conduit, we became connected with elite, they use the term KOL, or key opinion leaders in the overall bone health. And so we were connected with outstanding key opinion leaders. And one of them in the Netherlands is in Leiden University Medical Center. And she is now overheading the bone quality division at the hospital. And she's been using the test for many years, since the early days. And she's probably tested the most patients out there, her and the center in Barcelona. And it's remarkable to hear the stories that they tell about the patients, because when you're a major medical facility, you receive a wide range of patients. So she'll have patients that come in, Dr. Appelman, she'll have patients that come in who are in a very rare disease condition that really affects their skeleton in different ways. And she will deploy the tool to gain insights into what's happening in that patient. And then she'll get patients that have had other issues where they are coming in with multiple fractures, or they're coming in with complicated kind of disease states that are making the overall diagnosis challenging. And she deployed the tool in those cases, and also studied a lot of groups and published a lot of work, the early stages of figuring out what's happening in your bone health. Because there's areas that, and I should probably take a step back, is there are specific areas where dense bones do not correlate well at all with how strong your bones are.
Right.
And there's certain rare diseases where what's breaking down is not necessarily the mineral or density part, it's everything else. And so they know that you can have your bone density can be normal, but your bones are very poor, they're weak, they're fragile. And so one of the things that they did at Leiden is they started studying a lot of these subpopulations and showing that even though their bone densities could be more normal, their bone scores were decreased, which suggests their bone tissue is not responding well at all to our challenge, to our test. And so she pioneered a lot of the early work in that space, starting with groups in rare diseases and working our way all the way out to osteopenia, which is sort of that mainstream area of bone health, and showing that in her studies that our scores decreased in patients that have either the disease states and complications or prior fractures and things like that.
Wow. So she's using it just across the board for general health, just gathering information, more information on any type of patient.
Well, the patient she deals with can often be challenging cases, right? And so she deploys, I think, the mindset that is, if I can gather more information here, that's far better for this patient than making a guess.
Yeah.
I don't want to misquote her, but in a general conversation, the description she used was something that I thought was interesting. And essentially what she said is, if bone density is the core metric for understanding someone's bone health, if that metric got us to a state where the patient has a lot of problems, then that metric's probably not the state we should use to figure out how to get them out of the problem. We should probably bring in a different metric. And so I thought that was kind of an insightful way that she is looking at it.
That's great.
Is there anything else you would like our listeners to be aware of in this, or have we covered it all?
Well, we're pretty excited about some results that'll be coming out in the near future. We've been working for a number of years on a study in collaboration with Washington University in St. Louis and a kind of well-known key opinion leader researcher there. And essentially what the results will do is or what the study is doing is since there is no easy way to measure how strong your bones are, one of the best ways to do it is in a laboratory where you can actually take, it's maybe too graphic, but you can actually take donation tissues from people who have donated their tissue to science, and you can be able to use engineering tools to accurately assess the strength of the bone. And so the study we've been running is looking at our measurement, which was at the midshaft of the shin, and comparing it to how strong the bones are in the spine, in the wrist, and in the hip, because those are the three areas of greatest interest. And so far, the preliminary results are very exciting. They show that the score is significantly correlated with the strength of the bone at the hip, wrist, and spine. And that in certain situations, it significantly outperforms bone density in those results. And then, there's some other granularities of the study that we think are also going to be exciting, but they're more nuanced for the physician audience to really show why what we're measuring is unique and special. And we'll talk about those when the studies finally come out, but that's on the horizon. We're hoping that that'll be something that we can share with everybody as early as kind of January, February, or at least, early 2024.
This is really good news because one of the frequent questions I get from patients is, how do you know how the rest of my bones are when you're just testing my shin bone? And exactly that. I mean, I think it's generally accepted that there is correlation with the other technologies as well, but this is perhaps being a little more profound, a little more accurate.
Well, and it's the necessary steps that you take when you're in our position, right?
Right.
You just keep chipping away at the data that people need to see. And it's also a leap that a lot of other tools make. It's a leap that's been made when you look at bone density and someone has an osteoporotic hip. Generally, the consensus is your bone's probably not good elsewhere.
Yeah.
Even though the scan's only of the hip. Mm-hmm. And then also we know that there's other metrics out there that look at one particular area. And I think the way that one could think about it is that if you think of your bone as a building that's made out of brick, different parts of the building will have more bricks and less cement, or certain parts of the building will have less bricks and different cement. But ultimately, what we think we're trying to understand is how good is the brick and cement, right? How is it performing? And if, no matter how big the structure is, right, if the building blocks are having issues, then the structure itself would have issues. And so that's why we say when we're looking at things that we call it the tissue scale, we're not surprised when the results show the connection between things, because we know that we believe that if the tissue is compromised, then even if it's layered differently in a different part of the body, it's still compromised tissue, right? And that's why we think it works.
It's important stuff.
Really fantastic. So I also have a fun fact about you that you admitted yourself, is that you are often comments have made about you that you can't sit still.
That's my fun fact too, by the way.
Yeah, it's so
it drives everyone crazy.
It's a family joke, because I'm one of the people whose legs always going up and down.
Yeah.
And so my sister at the dinner table will be like, Peter,
well, the dinner
or
table,
even if I'm on the couch.
Yeah, but the dinner table to me is almost like going to jail, because if I'm at something where I have to sit for too long, I'm like, when can I be okay leaving the dinner table without being rude or something?
I mean, I can sit through. I enjoy a good conversation over dinner, but sitting still has been one of those things. This has always been a challenge, even when I was young. So
it's called a hummingbird. It's called a hummingbird. We're hummingbirds.
I'll take it.
That's like what we do to feel like free. To feel free and productive, we have to keep moving. It's actually a personality. It's called a hummingbird.
I didn't know that.
Yeah, Google it.
I'm going to Google it.
So thanks, you two hummingbirds.
Yeah.
My pleasure.
Thanks for being on
having
the
me.
Vagina Doctor podcast.
No, it's my pleasure. Thank you for having me.
Well, thanks for listening. We're getting really good feedback. We'd really appreciate a review on Apple Podcast, Spotify, or wherever you're listening. Thank you. You can always DM the Vagina Doctor Instagram with any questions or topics you'd like to learn more about, or email us. The Vagina Doctor Podcast. It all starts here.